Hello and welcome to Dragon Bites, the paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Asim, one of the paediatric trainees here in Wales and one of the presenters for Dragon Bites. This week we have the final episode of our left to right shunt series that we've been doing with Professor Uzun, fetal and paediatric cardiologist at the University Hospital of Wales. We're now going to complete the series with our final part of our Atrioventricular Septal Defect episode. Anyway, let's get started.
So you got the ECG and the patient doesn't have any sign of pulmonary hypertension, but there is biventricular hypertrophy, large atria, right atrium, large left atrium, so volume loading. So a patient is symptomatic. What shall we do? We're going to do a few things. One, we're going to optimize patient's airway. We're going to optimize patient's feeding. We're going to optimize patient's calorie intake. We're going to optimize patient's circulating volume, volume reduction, diuretics. And now we're going to optimize patient's vascular tone or inotropy or contractility. So this is the mainstay of our management.
Sure. So very similar to VSD management.
Absolutely. There is absolutely no difference. Classic standard VSD type scenario. In these patients, pulmonary pressure rises very quickly as a result of the other associated problems like upper respiratory tract problems, tonsillitis and recurrent infections. So therefore ENT input and respirology input is essential for these patients. And if there is no airway problem, if there is no obstructive sleep apnea, if there is no respiratory issue, but patient is having persistent low saturations, then you would be worried. So you would refer this patient for surgery sooner than later, instead of wasting time with diuretics and other medications in the hope of controlling heart failure and gaining time so a baby can reach sort of 4 or 5 kilograms.
Yeah.
When this baby comes to you, you start diuretics. Usually we combine it with sort of 2 diuretics will be combined, furosemide and spironolactone, or chlorothiazide if baby has some problem with calcium retention. And you put them on sometimes digoxin, if necessary, slow down the heart rate for better filling. And a bit of inotropy. Captopril. So captopril is the mainstay of heart failure treatment in children. So you would start captopril with a bit of test dose, check Uzun, and then give them small dose of captopril and check baby's blood pressure every 15 minutes, half an hour, an hour. And if baby tolerates, and then check Uzun. If there's no rise in potassium, no sign of kidney dysfunction, then you gradually increase it. Spironolactone is the same. You can give them twice a day, or furosemide can be given 3 times a day. Both of them can be given 3 times a day if necessary. Captopril also 8 hourly, as you know. Then what would you do? Because you're not treating the abnormality, are you?
Yeah.
Eventually you have to refer this patient for surgery. When is the best timing?
So presumably this is yet again another weight dependent factor. Yeah.
Wonderful. The surgery, success of surgery dependent on a few things. One of them is gestation, and the other one is weight at birth. And of course the associated lesions and associated abnormalities also have a huge impact on the outcomes. So weight dependent, time dependent, symptoms dependent. So ideally in AV septal defect we don't delay surgery beyond 5-6 months of age. In VSD you can delay it, but in AV septal defect pulmonary hypertension develops very quickly. So the difference between VSD and AV septal defect is that in VSD you can afford to wait a little bit longer to see whether the nature will play its trick and will make the VSD smaller, and you can avoid surgery, or you can buy time to do device closure if it is muscular VSD.
Yeah.
But in a VSD, you don't have such luxury. So you do tend to operate when they reach 4 and 5 kilogram. That's your aim.
Mm-hmm.
And 5 kilogram would be ideal. They usually get operation at 3.5, 4 months of age, definitely before 6 months of age, sometime 5 months, but they are certain not beyond 6 months.
Mm-hmm.
And surgery involves, can you imagine what sort of repair we would do? So you have 2 holes, you have also common valve.
Yeah.
Think of those common shared leaflets, superior and inferior bridging leaflets, yeah, on top of the septum and below the primum ASD.
Yeah.
So there are 2 holes, and there are 2 separate inlets, but now they're single, so you need to separate them. So what you need to do, you need to put a patch to separate or to repair the ventricular septal defect.
Yep.
And then patch to repair the atrial septal defect.
Mm-hmm.
And then you put the patch in such a way that you also divide those common leaflets into 2 components, one for the right, one for the left.
Mm-hmm.
Does it make sense?
Yeah, yeah.
But still, those shared ones, one superior, one inferior, you split them into 2 equally. Well, what happened on this side? Still, they're not together. They're separated from each other. So you need to put them together to turn. Now, what you've done, the mitral leaflet, you turn mitral or left-sided inlet into 3 components, didn't you?
Yeah.
That's my point. You got 3 components. You need to stitch them, repair the superior and bridging leaflets on the left side, and turn them into a single one leaflet.
Okay.
Yeah. And repair of left-sided inlet, and the repair of the right-sided inlet, and turn right-sided inlet into trifoliate.
A trifoliate.
Yeah. Valve, and then mitral valve into bifoliate valve.
Yeah.
That is the aim.
Mm-hmm.
Some surgeons do single patch technique, but recently most people would do 2 patch technique. So you put 2 separate patch, and some people pull them VSD upwards and use just 1 patch.
Mm-hmm.
But 2 patch repair preferred, and depending on the size of VSD, of course, if the VSD is not very big, you can do single patch repair. So surgeon decides on that on the basis of what information you provided to the surgeon on echocardiogram. Long-term outcome in these patients and mortality with surgery is pretty good. In the UK, it's no more than 5-6% 30-day mortality, and again, 1-year mortality is no more than perhaps 8-10% in the UK.
Mm-hmm.
And long-term survival, 20-year survival, is over 80% in these patients. So that's quite good compared to before. What else would you think of in these patients that is relevant to pediatricians? So do you think we should consider something else? Say this patient came to you with abdominal obstruction, and surgeon found inferior vena cava was not coming to the heart, and it was interrupted, and patient had 2 neck veins going into the atrium separately to the right atrium, so bilateral superior vena cava. And they also noted that this patient had no spleen or multiple spleens. Patient comes with acute abdomen, and you looked at the patient's chest x-ray, and it looks like he has 2 similar lungs, and the bronchi look exactly the same. So what would be your thinking?
So this is what we were talking about, isomerism.
Wonderful. We have seen patients who had operation, came back from surgery, and months after admitted to hospital with malrotation. So it can happen. Sometimes isomerism may not be bound or obvious.
Yeah.
It can even happen with normal looking chambers.
Wow.
So you need to be very, very careful. So if you come across such scenario, you should be thinking of that. It's very important. And how would you diagnose malrotation prior to surgery? Barium meal.
Barium meal, yeah.
Absolutely. Brilliant. Well, I think I have probably gone through everything.
Yeah.
What is our routine? What do we do in the end?
So we normally end by going over our 3 take-home messages, don't
Excellent.
we?
And you tell 3, and then I tell 3, don't I?
Okay, fab.
So, 3 messages from you, 3 messages from myself and yourself.
So my first message, from an anatomical perspective, we're looking at a primum ASD, an inlet VSD, alongside 2 valve leaflets that are common valve leaflets that join what would have been the mitral and tricuspid valve, but aren't really those anymore. So that's from an anatomical perspective. From a presentation perspective, I suppose it presents very much like we'd expect a VSD to present, and so much of our treatment methods follow those lines. More importantly, though, from an intervention and management perspective, we do not have the time to play with that we would do with a VSD, so we have to intervene earlier in children who have an AVSD.
Excellent. Absolutely wonderful. Spot on. So I'm going to go into clinical take-home messages. So I will start with clinical examination. So murmur, pansystolic murmur in these patients, then that would be due to not VSD. We don't expect pansystolic murmur in these patients. VSD is usually large and the pressures are equal. The murmur is a function of different pressures between the 2 chambers, remember. So murmur in AV septal defect patients would be due to leaky valves, not VSD.
Yeah.
Unless VSD is restricted, unless VSD is small.
Yeah.
Remember. Then the VSD would be heard by the left sternlet. Okay. 1 is VSD. VSD is due to leaky valves. If you have as good ears as Asim, then you would also hear diastolic rumble. This is listening, right? Second tip is on chest X-ray. What do you say on chest X-ray? You get pulmonary plethora, and then that plethora would show itself extending vascularity into the third, beyond 2/3 of lung fields, vertically divided, and the pulmonary arteries would be large. Main pulmonary artery or pulmonary conus would be prominent on the chest X-ray. ECG, what you're not going to forget, left axis deviation, left axis, particularly when it is associated with trisomy 21. Those are the 3 things I would like to give you from clinical and investigational point of view.
Absolutely.
I hope listeners will enjoy this. I enjoy this.
Yeah, I always enjoy this. Thank you very much, Professor Uzun.
You're welcome. So looking forward to seeing you again.
Yeah.
And thank you for asking me to talk about it.
Thank you.
And I just wanted to say thank you again to Professor Orhan Uzun for taking so much time out to discuss all this cardiology with us. I hope you've all found this as useful as I have, and it should hopefully help you with your exams and some of your clinical practice. We're going to take a brief break over Easter for the next 3 to 4 weeks while we record some more episodes for you, but we'll see you before long. Thank you for listening to Dragon Bites.